starting it right now.
Okay. Well, welcome to the feeding and swallowing session in the schools. This session is specifically designed for new SLPs and new SLPAs. How many of you feel comfortable with feeding and swallowing? Can you raise your hands? You can use your little raise your hand bar on there, and Libby can let me know.
My only experience has been with my own babies, so I don't think I can raise my hand.
Okay, that's absolutely fine. That's good. That's good. I mean, I want you to know your limitations and where you feel like you're not as strong and might need support or extra training. So that's great. So, Libby, I can't see. Did other people say they feel comfortable with that?
I don't see any hands.
Okay. All right. Well, I can tell you right off the bat that I do not feel comfortable with it. I've never had to do it. And I've never had the training to do it. When I graduated over 30 years ago, we didn't have feeding and swallowing courses. We didn't have dysphagia courses. So I would definitely have to have some professional development in order to do it, and then some experience being supervised to do it. But it is part of our ethical responsibility if we work in the schools to be able to perform whatever service the student needs. So if you would happen to get a student who needs some swallowing support and some feeding collaboration, then you would definitely need to try to find some professional development and someone to help with supervising you for a while. We have Pam Holland at Marshall University, who's the only person in West Virginia who's certified as a dysphagia therapist to do feeding and swallowing programs. And she has done a training for us before, and actually a lot of this information came from the training she did for us before. And she also has offered to do some webinars for us and offered to provide some clinical support via, video conferencing platforms for people who are having to do it and don't feel comfortable. So just know that that's available. If something happens and you do get a student who requires some feeding and swallowing services, but determining whether or not they need it from school is what we're going to be talking about today. Remember, when you work in the school system and you're providing educational services as an SLP, then there has to be an educational relevance to the service you provide. And it needs to provide access to the student to be able to access their educational environment. And that's according to the Individuals with Disabilities Education Act. And so when you think about it, is feeding and swallowing in the schools educationally relevant? You can just type in the chat box, yes, no, or maybe. Do we have any answers, Libby?
We have people typing.
Okay.
Maybe.
Mm-hmm.
Maybe. Maybe. Three maybes.
Guess what? You guys got it right, because it may be educationally relevant and it may not. It depends on a lot of factors, and we're going to be talking about those next. West Virginia guidelines, and it looks like I didn't finish this slide. I'm sorry. I'll have to go back and finish. I think I maybe moved it to the next page. Services for health-related disorders that affect the ability of the student to access their educational environment and prohibit full participation in the educational setting are mandated. So addressing feeding and swallowing is educationally relevant and part of the school system's responsibility. If students must be safe while eating at school, addressing feeding and swallowing disorders is educationally relevant and part of the school system's there. I didn't finish that slide. I apologize for that. Students must be safe while eating at school. They must be adequately nourished and hydrated so they can attend to and fully access the school curriculum. And I think that's the biggest factor to remember. They have to be able to be nourished and hydrated If they get dehydrated by going a whole day at school because they haven't get any access to liquids, and they're not tube fed, then that's something we would need to address. If they're not nourished, if they have a feeding program or require a feeding program, and it needs to be performed while they're at school in order for them to be nourished enough to stay at school all day, then that does become our responsibility. But it doesn't necessarily become a direct responsibility as far as being the service provider. Students must be healthy from aspiration pneumonia or other illnesses related to malnutrition and dehydration to maximize school attendance. Now, every time we talk about any issue, speech language pathologists always say, well, what does ASHA say about it? And that's always a great question to ask, because ASHA is our governing body as far as providing guidance and telling us what we ethically need to do. They define a feeding disorder. It includes difficulty getting foods into the mouth, food selectivity, refusal, and or difficulty with food textures and colors. Now, if you think about this, the only piece of that we would really assist with is getting food into the mouth, because food selectivity and refusal, if a student has food selectivity issues, I used to have students with autism who would only eat French fries, for example. That was their whole meal choice, every meal. That's the only thing they had limited themselves to. They had such a restricted food repertoire that French fries was the only thing they would eat. Now, they went to outside services and had feeding plans to address, introducing new foods and that kind of thing. And WVU's feeding clinic often provides those types of plans, as well as Marshall's. And those types of plans really need to be implemented at home, because I haven't seen one recently, but the ones I used to have to try to be involved in, we had to feed a student I think they had to take 2 or 3 bites every half hour and that kind of thing. Those kinds of things are not functional at school. And if the student can come to school and just eat French fries and make it through the day, it's not really that we need to directly work with them on trying to expand their food repertoire and accepting new textures and that kind of thing. That's more for an outside therapist to do. A swallowing disorder is difficulty managing foods and liquids once they're in the mouth. And that's where we're really going to be trying to help students develop the musculature and the movements of the swallowing mechanism to make that happen. But risks for both of these include malnutrition, dehydration, which we just said are the 2 reasons we need to be alert to helping a student so they can maintain their attendance or their access to school all day. Even if it's in, if they're getting virtual therapy, of course, we wouldn't have to be doing the direct service at that point, but we still could be a consultant to the parent and any of the other team members who might be working with that student. We have to watch for choking, of course, and aspiration and pneumonia. And this is the reason that we have to be very cautious about putting any type of feeding and swallowing services on an IEP. The reason I had you raise your hand when we first started the session is because some people feel very confident and comfortable doing swallowing therapy. They had like a dysphagia rotation in grad school and they loved it, and they're very confident and feel very capable to do it. But there are other therapists in the county who might receive, or even anywhere across the state, who might receive this student if they move or transferred or something like that, and they'll inherit the IEP that you write. So make sure that if you add the services to an IEP, which you absolutely can do, that you do it because the student needs it to access their educational environment, not just because you think, oh, I feel so comfortable with dysphagia, I'll go ahead and provide service for this student, even though he may not need it to access his environment. And that's happened a lot in the past. So we really try to be careful to make sure that the services are needed. And then if that student transfers, then yes, that therapist who receives them needs to, seek out the PD and request the supervision or the monitoring, whatever they feel like they need to keep the student safe. But it's just like this has happened several times with students who are English learners. Therapists will say, well, I speak Spanish, so I'll go ahead and work with this student. And because I can work with them in Spanish too. But, if the student didn't really meet the eligibility criteria or they're receiving services from an EL teacher, those services might not have been as necessary from the SLP. So just make sure it's not based on your confidence level that you either put the services on or deny the services, but make sure it's based on what the student actually needs to access his education. There's no eligibility. If you think about the eligibility forms that you've seen by now, there's no place to check off that a student qualifies for feeding and swallowing, and there's no dysphagia eligibility criteria. So, the eligibility areas are speech sound disorders, language fluency, voice, and special pragmatic communication disorder. But the way you would offer services for a student would be through you would still put it under speech, but a lot of these students qualify as other health impaired. And with that, you can add the services because it will be included in the PLAF or your present level for that student. And the diagnosis codes that you would use are in our Medicaid list of diagnosis codes. And they actually have some that are below the oral phase. We're going to get there in a second, but we'll talk about not going below the oral phase as far as treatment in the schools. So if you do have a student who's other health impaired, that's the perfect opportunity, especially if they have feeding issues, to go ahead and work with a team, establish a team like the OT, PT, maybe for positioning. The school health nurse can be part of the team, the classroom staff, and you would monitor and train the classroom staff how to keep the students safe at that point. So with the team approach, it can be used, like I said, for either issue, and the team should educate the school staff on the symptoms, support available resources in the school, and maintain frequent communication with the child's parents and physician. So, providing support and observing, because if you think about it, children, if they come to school and they're in person, they have a breakfast, break, a snack, a lunch, and possibly an afternoon snack. You can't be there to feed that student every one of those times, but you can help support the staff and keep them safe and make sure that they are positioning the student correctly, offering the right number of bites, waiting the right amount of time for the student to, deal with the bolus and get it down and that kind of thing. And then things to watch for is, if they're perhaps aspirating or having difficulty. So that's part of your responsibility, to be training that team and watching that team and observing and consulting and collaborating with them, but not actually performing the service. Now, you might have to demonstrate it the first time or so, but it's not something that you're going to be doing on a regular basis. And then there's just a list of all the team members that can be included. And actually, if you are doing anybody who has needs pureed foods or that kind of thing, you definitely need to get the cafeteria manager or the head cook involved with that, because if they have a doctor's order that they have to have that alternative diet, then the school has to provide it. So you'll be working with them and the building administrator as well. And then some parents might want to provide the food that they want their child to have. They might choose to puree them at home and send them because they're worried about the school not doing it to the texture they like and that kind of thing. So work with that, collaborate with that entire team to make sure that the services you're providing for that student are appropriate. And this is an ASHA statement, and this really holds true for any area, for AAC, for any area that you might be involved in, working as a speech language pathologist in the schools. because, you know, we're not like people who work in SNFs or in certain, you know, specific field facilities. We have to be able to address every issue. And so just always an important thing to remember. Only persons possessing a competent level of education, training, and experience should conduct assessment and intervention. And actually, you are never going to conduct a dysphagia evaluation at school. That's going to be done by an outside service provider, and the report will be provided, should be provided to you. You don't have the equipment, you don't have the facilities to do that in the school system. And honestly, I've had doctors tell parents that we could do them in the schools, and that's just absolutely incorrect. So, you know, if that should ever happen to you, be sure and contact your special education director and let them know, because it's a really fine line that you have to follow at that point. Excuse me, because if the child needs a dysphagia evaluation and you say, I can't treat your child until that happens, that's what you need to say. But they could also say, well, then you need to pay for it through the school system. And honestly, I think the number that I got last year from the nursing coordinator was that 95% of the kids in West Virginia have some form of insurance. The nursing nurses across the state, physicians across the state have worked very hard. And the insurance agencies have worked very hard to make sure that children are covered by insurance in West Virginia. So that shouldn't be an issue for the child's insurance to pay for it, but you might want to definitely let your special education director know that that request has been made, or that piece of testing is needed. And you might consult your nurse as well, because sometimes they can help with contacting physicians and explaining things, and, you know, help as an intermediary with parents so that they're just not hearing it from you. Okay, you guys probably already know this, but, you know, I know there are some therapists who are new to working in the school system who maybe haven't heard this for a while, who've been working in other facilities for many years. So just want to do a quick overview of this. And a swallowing disorder is also called dysphagia. The three phases of swallowing are oral, pharyngeal, and esophageal. Your child can have a problem during one or more of these phases, and your child can also have a feeding problem. So that's going to compound what they're going to be able to do. The three phases of swallowing, this shows how they go. And the oral preparatory phase and oral propulsion phase is the only phase that we treat in the school system. And the reason for that is, if you look at the pharyngeal phase, aspiration is most likely to occur here. We don't want to take any chances with any student aspirating either food or liquids that could cause pneumonia and then, you know, keep them from attending school. You know, it's a very fine line as far as treating for that too, because even kids who are in phase one, who are in oral phase, can have some aspiration too. So, you know, that's just the top phase that we will work with, and we shouldn't go anywhere below that. Although sometimes there, you know, there's a little bit of crossover. Just don't put on your Medicaid diagnosis code anything below the oral phase. Involuntary is totally reflexive in the pharyngeal phase, so, you know, that's not something we can control. And we don't have the rescue equipment available in the schools in case something should happen. Same thing for the lower esophageal phase. It's the lower esophageal sphincter that's involved. There can be gastroesophageal reflux, and we cannot treat that, anything below that in the school system. Now, what you'll find out with a lot of your students who have complex needs, meaning that they have a lot of different services, OT, PT, speech, you know, they might even have vision and hearing impaired services. Those students a lot of times receive outside private services as well. So be sure and collaborate with that outside therapist who may be treating them at the pharyngeal phase or the esophageal phase. But just remember, we don't ever go below the oral. That's to protect you, and especially to protect the student. With the oral phase, these are just some of the problems that might be included. Trouble sucking from a bottle. And those of you who've had preschools know that you have some preschoolers who come to school still using a bottle. Problems coordinating breathe, suck, swallow. My niece had that. My niece and nephew were premature, 11 weeks premature, and she had to wear a pulse oximeter when we fed her. And we had to try to get in so many cc's in them for the first 6 months. That was something that we had, that pulse oximeter, to show when she stopped breathing. They were both on monitors, so that if they're, if things started going south for them, those monitors went off, and we had equipment to deal with it. You don't have that in the school system. So these kind of issues can happen, though, with the oral phase. Problems closing the lips to get the food from a spoon or fork, or to keep the food in the mouth. Trouble chewing or moving the food and liquid from the mouth to the throat. Not being able to control food or liquid so that it goes into their throat too quickly. Having some food left in the mouth after the swallow, and getting residual food stuck in the cheek, called pocketing. With the pharyngeal phase, they can have a hard time starting to swallow. They can get liquid or food in the airway, called aspiration, and they can have some food or liquid stay in the throat, swallow, which is called residue. And with the esophageal phase, some problems could be food getting stuck as it moves from the throat to the esophagus, poor movement of the esophagus so food doesn't pass easily into the stomach, food coming back up, which is called reflux, and pockets in the esophagus that catch food and don't let it go into the stomach. So here again, you're not going to be doing anything at the esophageal or pharyngeal phases. You're only going to be treating if you're treating at the oral phase. And here it is again, in writing, in red, bold, and underlined. And I've already told you why we don't treat below the oral phase. And it's because we don't have the facilities at the school system to do it, and we can't take the chance on having a child aspirate at school. So that's the reason we don't treat them below the oral phase. Now, these are just some of the things that can cause feeding disorders, problems with nervous system from cerebral palsy or other disorders, gastrointestinal problems like reflux, premature birth and low birth weight, heart problems, cleft lip or palate, breathing problems, and developmental disorders like autism or Down syndrome. Feeding disorders may include difficulty eating with hands or from a spoon or fork, and that's where you can make sure that you're teaming with the OT to make that happen. Food refusal, like crunchy or smooth foods, and I work with a lot of students with autism, and even when we're doing cooking activities and telling them right up front, you don't have to taste it, you don't have to eat it, you just have to, touch it and be with us when we're doing this activity, that was enough to set them off. So, just know that those kinds of things can happen. Eating only certain foods like French fries or pizza, and I am talking about students that's all they would eat. The one student that I had that we tried the feeding program with, the reason they were willing at the school to go to that extent with him, he had a personal autism teacher, that he was the only student the autism teacher had, and it was going to prevent him from having a G tube put in. His nutrition was so poor that they were considering a G tube if he did not get some new foods added to his repertoire. Gagging easily when food is brought near the mouth, and I've definitely seen that happen. Having trouble paying attention long enough to eat a meal. Kids who are ADD or have autism, sometimes they can't sit at the table. They don't, have the attention span to do that. And so they take a long time to eat, usually more than 30 minutes. And that's a problem, of course, if you're at school, because they usually have a 30-minute lunch period. If you can get some food in them at school, though, and maybe not their entire lunch, at least they've had some food and some nutrition. And this is really important information for you to think about and watch for, and also share with anybody who's on your feeding team, and especially a paraprofessional or classroom aide who might be feeding a student during the meal times, or a classroom teacher too. Arching their back or stiffening up while feeding, becoming irritable or falling asleep while feeding, taking a long time to eat, more than 30 minutes, refusing food textures, like crunchy or smooth foods, drooling or spilling food or liquids from the mouth, gurgling or out of breath after eating, coughing or gagging during meals, getting pneumonia or respiratory infections a lot, spitting up or vomiting after eating, and not gaining weight. What can happen if a child has a feeding disorder? They, of course, need food to grow and develop, and a child who has trouble eating may not get enough food and water to stay healthy, not grow the way he or she should, be at risk for food going into the airway, and that aspiration is something we have to be really careful about. And then if that does happen, then they get respiratory viruses, infections, or pneumonia, and not like to eat in front of others. There are some who don't want people watching them eat, and being in a cafeteria setting or something like that, they just refuse to eat. So making accommodations and watching for all those issues is something really important for you to be aware of. Educational relevance says that students are entitled to a free and appropriate public education. In order for them to access their curriculum, students must have adequate nutrition and hydration. We've already talked about that. And then have the stamina to go to attend their classes. They need to be healthy enough to attend school. So many of our kids who have these issues develop pneumonia a lot, and they're at home, and they end up possibly on homebound because of it. And they're, when they are receiving the services, even if they're homebound and they still have some pneumonia, they of course don't feel like doing anything or participating. So it really takes the child out of the educational environment and out of the learning environment, and that's something we definitely don't want to have happen. They have to be able to efficiently eat their meals within a designated time and with their peers when possible. Now, when my niece and nephew were preemies, it usually took an hour to an hour and a half to feed them, like 15 cc's, and we had to feed them every 3 hours. So that, was significant, and that showed that they both had feeding and swallowing disorders at that point. Because my nephew had the same issues. He just didn't stop breathing like my niece did. So, those types of issues can really impact the student's access to their education. If they're, taking an hour to eat, then, that's a half an hour of instruction that they've missed and contact with the other students. So, just be aware of that. This is from the roles and responsibilities of SLPs in the schools, and I'm not going to read all of it to you, but I am going to talk about the numbered items that, speech language pathologists do have a unique skill set, and they have an integral role in education and are essential members of school faculties. Sometimes they don't realize how essential we are because, we have kind of gotten into the rut, and I'm just calling it a rut or a habit, the last probably 20 years of referring a lot of students for articulation errors, especially mild articulation errors, referring them for service, and that makes up the majority of a lot of people's caseloads. Well, with that, classroom teachers and building administrators think that what we do is play games and teach kids how to say R. Our job is so much more broad than that. And we have such a more amazing skill set than they even know we have. But just remember, you are an integral part of that faculty, and the collaboration that you can provide and the support you can provide to your feeding team and for a student is immeasurable. We help students meet performance standards of a particular school district and state by assuming range of responsibilities. We work in partnership with others to meet students' needs, and that's where that collaboration piece comes in. And we provide direction in defining their roles and responsibilities and ensuring appropriate services to students. So, we can definitely be a leader as far as the feeding team's concerned, and telling them, we need to, work collaboratively and this is what we need from the OT, and this is what we need from the nurse, and this is what we need from the cafeteria manager, and this is what you're going to get from me. So just knowing that that we need to accept those responsibilities and not shy away from them is important for you to remember. Now, when you talk about students with autism, you're going to have a lot of students with autism who are perfectly capable of chewing and swallowing and that kind of thing, but you're going to have some issues around feeding that you're going to come up with, you're going to encounter. And some of those could be social interaction and engagement. Some of them, like I said, don't want people to watch them eat. They're distracted by it being in a huge cafeteria and have difficulty with that. So that affects how they perform in school. And then there can be behavior, nutrition, and ADHD issues for them. If they're in a large cafeteria, you might see more behavior. That's when we would see a lot of student behavior, because what happens is some of them eat very quickly. You know, they know what they want. Their parents have usually sent their lunch in a lot of cases. And if they don't have any food preferences, then they've eaten their cafeteria meal pretty quickly. And then they're expected to sit for the next 15 minutes. So by providing like iPads or something to keep them occupied, or fidgets or something to keep them occupied during that time they need to sit with the other students, those simple kinds of things can make a difference for a student who has autism. Because, you know, what happens then is if they want to get up and move around and they can't, then they have a meltdown. And then everybody in the cafeteria sees it. And, you know, it's a whole disruption to everyone. So, you know, just trying to make some proactive decisions about students and trying to provide them with what they need. You know, people say, well, they'll be dependent on having an iPad anytime they want it then. You can set it up so that they have to, you know, finish their meal first, you know, with a visual. Show them eat first, then iPad. Then you might set a timer to let them know when they need to get off the iPad. And honestly, you know, people will just try to reach over and take iPads away, and that's the very worst thing you could do for a student with autism. You know, visuals to let them know what's going to happen first, even though you're telling them. Their auditory processing can be so disordered that they don't understand what you're telling them. And being able to see what's going to happen and when things are over really helps. So, you know, just remember to provide as many visuals as you can for them. And then, you know, you can make the time shorter and shorter that they are on the iPad, and then and then show them a visual. Now we're going to wait for 3 minutes, or we're going to wait for 5 minutes, and just keep working it that way. But with you being proactive and being in control instead of being reactive and just, you know, having to put the student in timeout or whatever the positive behavior support plan says to do, or the BIP, behavior intervention plan says to do for that student, you can be proactive and not have to implement that plan. This is just a video link. I'm not going to go to it this morning because we don't have time. But this is just a video link to tell you some more information about children with autism that I think is very helpful for you. These are just some prevention ideas to use with preschool students and school-age students who have difficulty or aversions with textures, because a lot of times you'll hear about a student being tactily defensive, and sometimes it's being touched, you know, someone putting their hands on them. But sometimes, too, it could be them touching something. So, you know, for instance, something that's gritty like sand may really be aversive to some students, while others absolutely love it. So getting to know that student and working with your OT to determine what textures they do and don't like is very important. But, you know, just being able to collaborate with that classroom teacher and say, you know, because this child has some texture aversions, you know, there might be some things that you could talk about or activities you could do in language arts to help address that, and tell them how to structure it so that it's not disruptive. Same thing with math, and the same thing with art. You know, you can finger paint with foods. You can make a rainbow out of cereal like this picture shows. You can do color matching activities. There are so many different things that you can do that isn't is part of the child's routine and their, you know, during their math time or their language arts time, but it doesn't interfere with their participation in the activity while teaching them to accept those textures and that kind of thing. So these are just some ways you can collaborate with the preschool teachers, because preschool teachers are always doing art and possibly cooking on Fridays and different activities that involve textures, and even textures in their centers and their water table or their sand tables and that kind of thing. This is just a YUM scale that Pam Holland had shared with us. So if you are working on a student or the classroom staff is working with the student, and they're trying to get the student to rate the food that they've just eaten, they could use this scale, and we would go over them with them, of course, and tell them what each one of those means, but you would also be trying to move them from super yuck to super yum, or at least moving them off super yuck. So this is just a cute little chart you can use. And this is a website, Dr. Yum's Class Party Toolbox, that you can access, and they have all different kinds of activities. I used to do the one in the top corner. At Christmas, we would have kids take ice cream cones, like the pointed kind, the sugar cones, and turn them upside down and put icing on the outside and then decorate them with candy. For those students who had texture aversions, that was a really difficult activity. So we kind of broke it down for them and did theirs in stages. But, anything you can do to introduce the textures, in some cases, you can embed that into an activity and not really have that as a goal on your IEP, but you can be trying to support that student by addressing those issues during your activity. And this is just a sorting activity where students are taking foods and touching them, and then that one little girl's cutting up peppers, but then they're sorting them according to colors. And this website, Pam Holland shared as well, is called Choose My Plate, and they have games and songs and activity sheets, and they have them for all different levels, like preschool through grade 5, I think. So if you have a student who's working with, on feeding especially, this is a good website to get some ideas to share with your classroom teacher and your classroom para who's working with that student on feeding. Now, when you get a student who you think needs swallowing support, be sure and ask for the most recent swallow studies that have been done. Request records from the physician, and your county should have a county form for doing that. You can contact your lead therapist if you have one, or your special education director to request that form, and you do need a parent signature for that. And you also want to request to be able to consult with a physician or any outside treating SLP. So here again, county forms with parent signatures. And one reason that's extremely important is that you will honestly have parents who come in because they think they're doing the right thing for their child. And they'll come in and tell you, my child is now on solid foods, or my child is now eating pureed foods, even though they still have a G-tube. So it's always important to take whatever you can see in writing as opposed to what the parent tells you, because sometimes the parents are wanting to move their child forward and they're just not ready and they don't understand that. And you can tell when that's happening because you'll hear those signs of somebody who's been aspirating, or you'll see those signs of somebody who is arching their back and all that kind of thing and having difficulty breathing. And that's important to bring to the physician's attention. And it's also important for you to make sure you protect that student by getting that most recent study. And you can agree with the school nurse to get that information or to have her contact the physician. Like I said, parents will say their children are on solid foods, but they may not be. So always make sure you receive clearance from someone other than the parent. And I hate to say that, but like I said, they of course have the child's best interest at heart, and they think they're doing the right thing. But in a lot of cases, it's putting the child in danger. And I've had so many therapists contact me and say, I've told the parent that child is aspirating, and they still won't take them to the doctor. In those cases, make sure you document everything that you've said and done. Make sure you've contacted the health nurse to have her contact the parent, because by that way, they're not just hearing it from you. Again, they're hearing it from the health nurse, and sometimes that makes a difference. Sometimes the health nurse can reach out to the physician and say, look, we're really concerned. We think this kid might be developing pneumonia, or he's aspirating too much. And, the physician can handle it too. But always watch for those signs of aspiration or choking or inability to handle solids. Pleasure feeding. With pleasure feeding, some physicians will issue an order for pleasure feeding, which allows for minimal amounts of oral feeding and drinking. This is typically because they may know that the child may aspirate some, but with them at this point, for some of these students, they feel like their quality of life, they need to be able to enjoy some food and drinks. So in those cases, make sure that you have authorization for it, and make sure that the parent sends you the foods that they want the child to use. Because even things like popsicles that you could stick in their mouth and maybe control, or suckers that you could just stick in their mouth and let them kind of lick and taste the flavor and that kind of thing, they could bite those popsicles off. Some of them could. And so just always have the parent send you whatever they want you to use, and make sure the child doesn't really swallow that much. I mean, I've watched therapists use bananas, and they let them lick them and get some of the banana on their tongue and that kind of thing, but never enough to let them have a possibility of choking. These are some of the resources that I used for and these are some websites that have some other really good information for you. I've also uploaded an ASHA document on feeding and swallowing to your Teams group and files. I've uploaded 2 documents there for you to have as reference, and I've also uploaded the PowerPoint, although I saw a couple of errors on the PowerPoint, so I apologize for that. Your lead therapist, if you have a lead therapist in your county, should have the Emily Homer book, Feeding and Swallowing in the Schools, because we provided it for them. So if you get a student who, you're going to have to do this with, you might want to ask to borrow that book. And if you're really feeling uncomfortable about doing anything with feeding and swallowing, be sure and reach out to us and let us know so that we can contact Pam Holland and see if we can get some support for you. So just know that that's available for you too. Are there any questions about anything that we talked about this morning? I know it was a lot of information.
I just have one quick question.
Sure.
When we are in the schools, I understand that it's only the oral.
Mm-hmm.
But if we were working in like a nursing home or hospital type situation, then as speech therapists, are we required to do the other 2 phases of swallowing?
I think you are. I'm
Okay.
saying that just based on my experience and what I've heard. Not my personal experience doing it, but my experience of what I've heard from other therapists. That's what they do. But if you think about it, they're at a facility that has the rescue equipment available. And if they're doing it in a hospital setting, of course, they didn't have physicians who can come in and help if something happens or goes wrong. And that's the reason we only stay at the oral phase. But just remember that choking and aspiration can happen at the oral phase too. So, just be very, very discriminating about adding feeding or swallowing services to a student's IEP. And if you're doing feeding, your role should be as the possibly the team leader or one of the main collaborators on keeping kids safe and making sure that paraprofessionals are doing what they need to do for those kids and keeping them safe. But, for swallowing, you could be doing some of the exercises and that kind of thing that are necessary, or, whatever you would use to treat dysphagia, but just keeping that child safe while doing it.
Okay, thank you.
Sure.
I've included the the form or the survey you need to complete to get a certificate for today's training. It has been approved by the Licensing Board of West Virginia. And of course, it would also qualify for professional development. So in order to get your certificate, please complete the form and use the link to access that form as soon as possible, and we'll get them sent out to you. I see Danya is typing. And Leanne, I'm going to go ahead and stop the recording.
Great.